think it's very helpful to have this understanding of a myocardial relaxation and stiffness, as Dr. Day just discussed. And I'll be talking to you for about next 20 minutes with the new guidelines. And so the ASC prepared with the ESCVI 2016, and I hope, which is very much preload dependent. And as you can see here with the normal filling, as you already heard, that the predominant filling is during early diastole with some coming with atrial contraction. But the early diastolic dysfunction is related to the abnormal myocardial relaxation, which is the earliest manifestation of diastolic dysfunction, so that with the delayed relaxation, left ventricular pressure fall is slowed, so that the mitral valve opens at the low pressure crossover, so the E velocity is much lower at the early abnormal relaxation, with the significant augmentation of filling with atrial contraction, as you see here. But it's important to know that in this particular setting, grade 1 diastolic dysfunction, the main problem is the early diastolic dysfunction with the delayed relaxation, but filling pressure is still normal. Filling pressure is still not elevated. But with the worsening of diastolic dysfunction, with the increased filling pressure, now pressure crossover between the left atrium and the ventricle move closer to the aortic valve closure with a higher pressure, so the E velocity increases again, and A velocity is about halfway. So that this particular mitral inflow velocity looks similar to the normal mitral inflow velocity, so that's what we call pseudo-normalization. So just looking at mitral inflow velocity alone, it'll be difficult for us to tell whether this is the true diastolic function, normal diastolic function, or pseudo-normal diastolic function here. And then with the further increase in filling pressure restrictive, it's going to be much taller E velocity or the short decel time and very small A velocities. So when we start doing it about 30 years ago, so it was a lot of criticism for the mitral inflow velocity because it's very much preload dependent. But now what we know we can do is to tell the myocardial relaxation by tissue Doppler velocities, because the annulus velocity, early diastolic E prime velocity, is inversely correlated with the tau, so that as relaxation decreases with the higher tau, E velocity will decrease, as you see here. So that all stages of diastolic dysfunction, E prime velocity is decreased. So now, combining the mitral inflow and mitral annulus velocity, we can classify those diastolic function, normal, grade 1, grade 2, grade 3, okay? So this is the data that we put together many years ago, and then since the E velocity increases with the high filling pressure and E prime velocity is reduced, E over E prime velocity increases with the filling pressure. So if you look at this, the dots with 100 patients, when E over E prime velocity is greater than 15, almost all of them have a high filling pressure, a wedge of greater than 15. But if it's lower than 8, it's going to be relatively normal filling pressure. In between, we have to do some other things because it's hard to tell which way it can go. It can be higher or it can be lower filling pressures. So we, the group, 8 members of the diastology group at the ASC and then EACVI put together simple parameters to help you, because the initial one in 2009 was too complicated with the 12 or 13 variables. And we felt that using E prime velocity, which is the indicator of a myocardial relaxation, which is the prime determinant of the diastolic dysfunction, and E over E prime as a parameter for the high filling pressures. And also when filling pressure is high, most of patients, pulmonary artery systolic pressure is increased, so that we use a TR velocity, and 2.8 is normal, or low is normal, and LA volume will increase as we have diastolic dysfunction increases with the difficulty in filling, and upper normal will be 34 ml per meter square. So we decided that we use 4 parameters initially, and then majority, if you have three or more parameters are normal, then that's normal diastolic function. If 3 or more are abnormal, there will be abnormal diastolic dysfunction. As you see here, the first algorithm we published. So we use 4 parameters, and then 3 are more are normal than normal diastolic function, and 3 or more are abnormal will be abnormal diastolic function. But there's some problems with these diagrams. If I have time, I'll come back to it a little later. And then 2 and 2, with indeterminate, then we have to use some other parameters, that the veins and the Valsalva maneuvers and other things, as we see here. So let me just go through some cases. This is a 71-year-old. LA volume is increased. 34 ml per meter square is upper normal, is on 39, is increased. But the other parameters, E prime velocity is a 10, and lateral and medial is a 9. So that tells you this individual, 71 years old, has a normal myocardial relaxation. And you cannot have diastolic dysfunction with normal relaxation, because the definition of diastolic dysfunction is you must have relaxation abnormality, right? So just looking at this patient has a relatively normal relaxation, normal diastolic function, just looking at E prime velocity, and also E over E prime is much lower than 15, normal filling pressure, and TR velocity was less than 2.8. So of 4 parameters, except for the left atrial volume, which is increased, despite of the increased left atrial volume, this person has normal diastolic function. Then you have to explain to clinician or yourself why LA volume is increased, whether it's a wrong measurement or there's some other reason for that. So echocardiography can give you that information. And here is LVOT TVI, or VTI is 30 centimeters, normal being 20 centimeters, or plus or minus 4. So TVI is directly related to stroke volume. This individual is well trained and heart rate of 46 beats per minute, and stroke volume is increased. And that's the reason that LA volume is increased, and then in the setting of the normal diastolic function. That's how you use those 4 parameters, and then majority rules that the determination of diastolic function. So these are the reason for LA enlargement. I just want to make sure that the LA enlargement does not always indicate the diastolic dysfunction. It can be a increased volume, someone with athlete's heart, or it can be measurement error. Just make sure that we measure the LA volume correctly. This 67-year-old, and I think I showed you this one during this morning's lecture, cardiomegaly and pulmonary venous congestion, thick walls, and you have the E velocity of 100 and A velocity of 30 centimeters per second. So E over A ratio is more than 3, right? And LA volume is increased, and E prime velocity 5. So severe reduction in myocardial relaxation. LA volume is increased, and E over E prime is increased. All 4 parameters, although we don't have TR velocities, 3 parameters already abnormal, and this patient has abnormal diastolic function and increased filling pressure because the E over E prime is more than 15. And that's how I use the initial algorithm. But there's a second algorithm in the guideline. If you already know that person has diastolic dysfunction, meaning E prime velocity, even without measuring, it will be reduced. I'll say about 5 centimeters per second. Those patients include depressed ejection fraction, someone with the EF of 35. You do not have to measure E prime to know E prime going to be 4, 5, 6 centimeters per second. It's a markedly reduced relaxation. Or someone I just showed you with the preserved EF with a known diastolic dysfunction. Thick walls, cardiac amyloid, ischemic coronary disease and things like that will be E prime velocity reduced. So in that particular case, since that particular person, you cannot have normal diastolic function, the best diastolic function you can have is the grade 1 diastolic function. So we go to the E over A ratio first. As I showed you, E over A ratio is a 2 or greater. that is a grade 3 diastolic dysfunction with increased LA pressures. If EOA ratio is 0.8 or less, with the E velocity of less than 50 centimeters per second, it automatically would be grade 1 diastolic dysfunction with a normal filling pressures. That will be the best diastolic function this individual can have, because they can have normal diastolic function, because E prime is abnormal, right? And then if those values are in between, then you go through those parameters I showed you to go through that, where that diastolic function classification be. So let me just show an example. Here is the EOA ratio is almost 3, and grade 3 diastolic dysfunction I showed you. And then this is an individual I just showed you again, that with the ratio of 3.3, so automatically going to be grade 3 diastolic dysfunction in case of the cardiac amyloidosis. 67-year-old, EF about 25%. E velocity and A velocity, you see that the EOA ratio is a 0.5, much less than 0.8. So whether you have a low EF or preserved EF, this particular pattern tells you this is an early diastolic dysfunction or best diastolic dysfunction in the setting of known diastolic function and has a normal filling pressures. Okay, this is grade 1 diastolic dysfunction, as you see here. But this patient, 2 months before, when he was admitted to the to hospital with the heart failure, this is a mitral inflow velocity. And I told you before that once E prime velocity is reduced, meaning your myocardial relaxation is reduced in your heart, it never changes. Unless you have the reversible cause, like ischemia or some apical ballooning syndrome, some reversible cause that you may, but most of the time, E prime velocity stays with you without change. So 2 months before that, E prime velocity is still 4 centimeters per second. This is when you just look at the EOA ratio, it's a 0.9, and then EOA prime is a 30. So high filling pressure, grade 2 diastolic dysfunction, and that's also supported by the TR velocity of 3 meters per second over here. And then only thing with the treatment, patient was feeling very poorly here, and we diuresed, we gave MACE inhibitors, and made this patient much, much better without change in any of relaxation property. But the only change we made is a filling pressure, right? Less volume overload with the diuretics and ACE inhibitors. So this is the best diastolic function this 67-year-old person can have with ischemic cardiomyopathies. So let me just go through the few difficult cases now. It can be a hypertropes, bundle branch block, annulus calcification. I'll come back to you with atrial fibrillation. And in those situations, you need other supportive measures. Dr. Cliswell, we're going to talk to you about the veins and then RVRT and things like that. So this is a hypertrope, the paper that we published. There's a very, very poor correlation between EOA prime here and the y-axis with the mean atrial pressures, right? But if you look at this diagram or scatter diagram very closely, it's interesting that if EOA prime is less than 15, really no one has high filling pressure. It's completely opposite. So if you look at the other way, this is the EOA prime in hypertrophic cardiomyopathy, and this is filling pressure. And this is, I already showed you before, with a non-hypertrophic patients. If EOA prime is greater than 15, it's all had high filling pressures. But here, you can look at this one, because of the hypertrophic cardiomyopathy with the thick walls, E prime velocity is markedly reduced. So that EOA prime is rarely less than 8. So that if it's less than 15, almost all of them has normal filling pressure. If it's greater than 15, then we have to figure out what the other parameters I showed you already. So this is the parameters we provided in the guideline. We still use the EOA prime of 15 as a sensitive marker, not specific marker. Then we look at LA volume, TR velocity, and also duration to figure out in hypertrophic cardiomyopathy. So just an example, apical hypertroph, the medial E prime is a 2, and lateral is a 5. because of significant difference in the thickness of the wall, you get different E prime velocities. However, the EOA prime is 40 medial and the lateral 15. I told you, it probably high filling pressure, but you cannot really tell because of the hypertrophic cardiomyopathy. Then you go to the TR velocity, that's a 3 meter per second, and very abnormal strain imaging here in the big left atrium. So this patient has a grade 2 diastolic dysfunction, even with hypertrophic cardiomyopathies. So 23-year-old though, I already showed you this diagram. If someone has the evidence of diastolic dysfunction, you go through the EOA ratio first, right? And if it's more than 2 or greater, it's a grade 3 diastolic dysfunction. So hypertroph, you think this patient should have diastolic dysfunction, so you go to the E velocity, A velocity here is about 2.5, 2.3 EOA ratio, go straight to the grade 3 diastolic dysfunction. But that's not always true, because 23-year-old hypertroph, even with the thick walls like that, they may have a normal relaxation, right? So you have to always go to the tissue velocity of the E prime, and E prime is 8 centimeter per second, and the lateral is 10 centimeter per second. This patient, for the 23-year-old, those E prime velocity is reduced, but still not bad enough to have a trouble with the diastolic filling, because the E prime ratio is 9, EOA prime ratio lateral is 7. So this is an example of a 23-year-old hypertrophic cardiomyopathy with a relatively normal filling, normal diastolic function, although a little bit reduced for 23-year-old, but overall filling pattern is not disturbed. And you can confirm that, because if you don't trust it, you can confirm that by other things like a Valsalva maneuvers, EOA ratio with a normal filling pressure, both the E and A velocity should decrease together. Normal filling pressures, okay? And then TR velocity is 2, and RVRT we'll hear about is a long at 120 milliseconds because relaxation abnormality. This tells you that this patient has a normal filling pressure, but relaxation is a little bit reduced for 23-year-old, but filling has not been disturbed. This is individuals with the 2 abnormalities. LA volume index is 54, TL is 2.8, it's upper normal though, and then E prime velocity is lateral is 8 and medial is 7. So it's a sort of half and half. You're not sure which way it's gonna go, because if it's abnormal, this is gonna be grade 3 diastolic dysfunction. If it's normal, this is truly normal diastolic function in that. But if you look at closely here, in this situation, if you do Valsalva, completely opposite. E velocity goes down and A velocity goes up. That's how you detect the grade 2 diastolic dysfunction in that particular patient. And also, very important parameters, here is a mid-diastolic flow velocity is a L wave, which indicates the delayed relaxation, which also can be seen in here, in pulmonary vein, and also the A velocity here ends before the atrial flow reversal in pulmonary vein. You're going to hear about that. And TR velocity remeasured to 2.83 meters per second. So this is a typical grade 2 dysfunction. So I just want to tell you about the L wave, because whenever you see L wave more than 40 centimeters per second is at least grade 2 diastolic dysfunction, because L wave indicates delayed relaxation. Because if you can see that here, with the L in a tissue Doppler, because of high filling pressure, you have the initial rise of the LV diastolic pressure, but relaxation continues after the early rise, and you have the pressure fall at the mid-diastole of the LV that allows more filling to the left ventricle and producing this L wave. So L wave indicates delayed relaxation, and most of the time it'll be at grade 2 diastolic dysfunction. I just want to skip that, skip this one branch block, and I just want to finish up with the mitral annulus calcification. This is a 92-year-old person with hypertension. I just take about a minute or two to finish up here. The E velocity is 80 centimeters per second. E prime is 40. So E of O prime is a 20, indicating this is a very high filling pressure, but pulmonary vein tells you normal filling, with the predominant systolic, and TR velocity is only 2 meters per second. There's a discrepancy here in this person, right? Why is that? When you look at the echocardiography a little bit closely, there are a lot of annulus calcification. Annulus calcification will make an E velocity high and E prime velocity low. So E of O E prime will be falsely elevated. So E of O E prime of 20, you are not sure. So what you have to do here is you have to look at RVRT, and this is a 90 millisecond indicating there's a normal filling pressure net. And this is also very nice diagram that was published from the Bill Zabi's lab, that in patients with the mitral annulus calcification, at least moderate degree, you don't go to the E of O E prime. You go for E of O E ratio first, and then look at the ratio, and as we discussed, and if it's in between 0.8 to 1.8, as in this patient, you go to the RBRT, and then that'll help you whether this patient has a normal filling pressure or high filling pressure. So I think I'm going to just stop here. We can go on and on and on with the multiple things, but I think that just using those 4 parameters first, and you should be able to assess diastolic dysfunction, majority of them, but in patients with the bundle branch block pacemakers and the mitral annulus calcification prosthesis and hypertrophic cardiomyopathy, those patients, you need further help. And Dr. Cliswell will tell you about the other important parameters for the veins and the IVRTs. Thank you very much for listening.
JetWorks is here. Together, let's work towards a healthier India.